Okay.
Yeah, I don't have that.
I'm unmuted now.
PowerPoint.
It's in there. I completely forgot to post this one. I was like
Was it published?
mindset on unit 11, and I forgot this is the rest of unit 10. So
You posted it under 11 though, but it's not. I'm confused. Sorry.
I have two. So there's one for the rest of unit 10, which is this, and then I have one under 11, which is
Okay.
11.
I'm getting you. Sorry.
So for those who don't have this one yet, just refresh and it should be there. That makes sense. All right. Okay. So drugs for hypercholesteremia, also known as anti-hyperlipidemics. Okay, I don't have the objectives on this PowerPoint, but you guys can look that up. Okay, so lipoproteins. So there's lipids, there's lipid cholesterol, triglycerides. You all heard it's the other half. I didn't even talk the first half. Already having problems. Okay. So lipid cholesterol, triglycerides, and phospholipids are found in the inner shell of proteins. There's four major categories, which we kind of talked about with Debbie. There's the high density lipoprotein, which is the HDL. That's the good protein. That's the healthy protein, the happy protein that we want. There's also low density lipoprotein, or the LDL, very low density VLDL, and then there's chylomicrons. Those are all bad. And then an excess of one or more lipids in the blood is considered hyperlipidemia. And that's when Debbie talked about the lab levels. So any change in any of those levels could be considered hyperlipidemia. So we're going to cover the non-pharmacological methods to control cholesterol. It's all the same stuff. I feel like they're Sunday school answers, right? For those who are familiar with that, right? Like, how are we going to stay healthy? We're going to exercise, stop smoking, stop drinking, or at least limit that, right? Reduce our sodium, reduce the cholesterol, reduce our saturated fat. So it's all those, same answers for pretty much every disease, how to prevent it, just be healthier. But with hyperlipidemia, in a lot of cases, diet alone won't lower the blood lipid levels, because there's a lot of cholesterol in a lot of foods, and having that strict diet, a lot of people don't like that and won't keep that going. So, and also 75 to 85% of cholesterol is endogenously derived. So if you do limit your diet really strictly, you're only affecting it like maybe 15% at the most, right? So you're already there. You can help it, of course, with these non-pharmacological ways, but you're going to need some medication as well. Okay. And they're preferred if they're done together. Okay, so these are our anti-hyperlipidemics. We've got bile acid sequestrants, fibrates, nicotinic acids, cholesterol absorption inhibitors, cholesterol absorption hepatic 3 hydroxyl 3 methylglutanyl coenzyme A. Woo! Say that 3 times fast. And then these little PCSK9 inhibitors, these are brand new. Your book doesn't even mention them, because when was your book published? What, 2012, I think, or 10, whatever. These came out in like 2017. So they're brand new. I'll just touch on them a little bit just so you know that there's still new drugs coming out. So bile acid sequestrants. This is our cholestyramine. This reduces the LDL by binding with bile acids in the intestines. So our body, sorry, I'm trying to talk through this real fast because we have a lot to go over. So our body uses cholesterol to make our bile, right? From our liver and gallbladder to help everything, right? So what this medication does is it binds to that bile and it doesn't really let it do anything. Well, in that case, like, our body says, wait, we need more bile, right? So now it's using more cholesterol to make the bile. So that's how we're reducing the cholesterol with this cholestyramine. It can be used with other drugs such as statins. It's not absorbed in the body. It just stays in the GI tract, and then, you poop it out. Fun times. It has no systemic side effects. It just binds to that bile, and you just go through your system and you poop it out. It comes in these packets, and it's like a gritty powder, orange flavored. You mix it, you drink it. It only works while you're taking it, though, right? If you stop taking it, it's not going to bind to that bile. You're not going to get any type of positive things from it if you're not taking it.
Is that what's in Metamucil or whatever?
No, Metamucil is more of like a fiber.
Oh, okay.
Yeah, but it's very similar to like the gritty powder orange stuff. But yeah, it's different. Metamucil is more like the fiber stuff.
Is this a lifetime drug, or can you correct hyperlipidemia? Like, if they took it for a set amount of time, can they correct the issue enough that they can then discontinue the medication?
No, this doesn't correct anything. It just
Your body's not going to self-adjust and stop making
right. No,
the bad fats or collecting bad fats. Okay.
right. Yeah, this isn't a correction. This would be any of the anti-hyperlipidemics are going to be a lifelong thing. And we'll get to that especially with the statins. Okay. So now we have our fibric acids or the fibrates. This is gemfibrozil. This does come up a lot clearer on like if you pull it up off the canvas instead of just on this isn't very clear. But for those like that. So this gemfibrozil, it's more effective for reducing the triglycerides and the VLDL production. Shouldn't be taken with anticoagulants because it can increase the risk of bleeding, and because it's high protein bound. It'll combine with those protein sites. Anticoagulant dose should be reduced while taking this drug because it can increase risk of bleeding, so you're going to decrease that. And then INR should be closely monitored if taken with anticoagulants. Okay. I'm going to let you guys read through those pictures later. Okay, so nicotinic acid. This is your niacin. Niacin is just fancy for vitamin B3. Okay? Reduces our VLDL and LDL. This is very effective medication, but it requires a really high dose to get good therapeutic response. And because of that really high dose, there's a lot of side effects, including flushing, GI upset, hepatotoxicity, hyperglycemia, amongst other things. And so a lot of people can't tolerate the high doses because of those side effects. So they're going to have problems staying and being compliant with that. You can take it with aspirin, and that does help with some of the side effects, and the compliance is increased with taking aspirin. But for a lot of people, this one's a really hard one to stay on.
So it's just not effective if they don't take a large dose.
Right. Yeah. Yeah, it takes a really large dose of this to have any real good results from it. Okay. Cholesterol absorption inhibitors. This is ezetimibe. This is a drug we're going to talk about. It inhibits the cholesterol absorption in the small intestine. So, works in the same place as cholestyramine, just in a different way. It just makes it so your body doesn't absorb any of the cholesterol that you're taking in. Reduces the serum cholesterol, LDL, and triglycerides. And then to get good optimal effect, it needs to be combined with a statin. This one isn't used very often. All right. Now, here is that really long word into HMG-CoA reductase inhibitors. That's that really long word at the very beginning. So these are your statin drugs. Lovastatin, rosuvastatin, and we have them all down here, the pravastatin, simvastatin, anything that ends in statin is going to be an anti-hyperlipidemic, and it's going to work this way. So it inhibits the enzyme HMG-CoA, and it reduces the cholesterol biosynthesis in the body. So it inhibits the cholesterol. It inhibits the endogenously made cholesterol. That makes sense?
Yeah.
Okay. These have a lot fewer adverse effects than any of the other ones. Okay. They're better tolerated. It's really easy. You just pop a pill. You don't have to drink a nasty drink and get the GI upset and the bloating and the belching and stuff from all, taking it that way. You don't have to take really high doses and have to deal with side effects. These are just so much better. They do have their own side effects, but they're a lot easily tolerated. A lot more easily tolerated. They're useful in decreasing CAD, and it actually, studies have shown it reduces mortality rates. Yay, right? We get to live longer. Okay, so with statins, and it messes with our cholesterol in our liver enzymes need to be monitored. You have to have an annual eye exam because it can affect your cataracts. Excuse me. Let me see if there's anything else. I think it's on the next level. Okay. So these statin drugs can be combined. We talked about that. You can combine them with the cholestyramine, any of the other drugs. Okay. And you can take them with hypertension drugs too, anti-hypertensive drugs to help with the blood pressure. Also with that, statin therapy is a lifetime commitment. And if they are on the statin drugs and you're looking at their levels and their levels decrease and they're normal and they keep taking them, but then they stop taking them, their levels will go back up as if they never even took them. Does that make sense? Like, it's only effective if they take the medication. If it doesn't, then their levels will just go back up to before they took the medication. And also, if they abruptly stop this type of medication, it increases their lipids threefold. And so they could get an MI really easily. So another drug you don't want to abruptly stop or we have problems. Okay, so here's the rosuvastatin. Let's see, what didn't we? So these statin drugs can cause muscle aches and some muscle pains. Rare, they could get rhabdomyolysis. Who knows what that is? Breakdown of the muscle. That's right, breakdown of the muscle. And it's a big breakdown, and who knows how to treat it? What was that, Amy? Cold bath. Anyone online know how to treat rhabdomyolysis?
It's super dangerous. So you have to get treatment medically, right away.
Right.
I don't know how, what they do besides fluids.
I don't know, what is it?
It's a breakdown of your muscle. So your muscles breaking down.
It's not in people who just are found lying down, they've been lying down for 3 days because their muscles haven't been moving. It's a breakdown of muscle. And they're lactic acid.
Here's a fun quick story. A few months ago, we had when it was prom, there was this sweet kid, and he wanted to buff up for prom, right? So he weightlifted like you wouldn't believe. And he got rhabdomyolysis. He ended up missing prom. It was the saddest thing. But
it increases your creatinine kinase, which is
what it can do, all that muscle breakdown can go in and it can destroy your kidneys. So what you do is you load them with fluid. You are giving them loads and loads and mounds of fluid, tons. As much as they can pretty much tolerate, really, so that you can flush that out of their system real fast. This kid was hospitalized for like 4 days. His levels would not go down. Anyway.
You have, like, people who are not so confused, but like on drugs and they're just like constantly pulling on like the restraints, or if they're like, because they don't feel the pain of when you're supposed to stop, so they'll keep going and going and going, and they'll rip their muscles.
Yeah. A lot of muscle contractures and stuff like that. So anyway, that's rare in this, but it can happen. But they do get the muscle aches, the muscle pain, so that's something you want to watch for. Monitor for compliance. Make sure that they're not stopping this abruptly, or they could increase their MI chances by 3 times. And then obtain a dietary history with that. So, any questions on that? Okay. So the PCSK9 inhibitors. Let me tell you about this real fast. So I don't know if online people can see. So everybody has, so this is like this little purple thing. That's your receptor for your LDL. Okay. And these are your LDLs, and the LDL comes on this receptor, and it takes this in to your liver, and your LDL gets destroyed, right? Well, these PCSK9s are little proteins, and what they do is they come on and they hook onto these. Oh, let me say this real fast. So these receptors bring the LDL down, right? You deal with the LDL, but then the receptors get recycled, and they come back up and get more. They're like a transporter, right? They bring the LDL down, take care of it, and then they go back up for more. Okay, they get recycled. Well, these little PCSK9s get on that receptor, and when the receptor pulls the LDL down into your liver destroys them both. Instead of just the LDL, it destroys the receptor. Your receptor is not recycled again, so it can't go up and pull more. So if your receptors are depleting, you have all this extra LDL in your system, okay? And they found that there's a lot of French people that have a lot of this PCSK9s, and that's why they have high lipid levels. So they have these PCSK9 inhibitors that go through and they inhibit that protein, so it can't tell the liver to destroy the receptor. Does that make sense? So now you have more receptors to grab that LDL and decrease your lipid levels. Kind of cool. Anyway, so they're new. These are the drugs. You won't be tested on them. But just know this is a new one coming through. So trying to keep this class updated with new stuff. Okay. It's this type of PCSK9. We all have them, but some families have more than others, which is why they found this is a problem. So it's a familial type thing, genetic. And then these are used also for patients with statin intolerance. So anyway, they're brand new, so they're probably pretty expensive. Okay, so now anything on hyperlipidemics? Questions? Got those? I know it's really fast. Peripheral blood flow. So this is where we're talking about our peripheral arterial disease, peripheral vascular disease, or Raynaud's disease. Who remembers learning about Raynaud's? We all do. Okay, good. So primary cause of PAD or PVD is arterial sclerosis and hyperlipidemia. Why would hyperlipidemia cause peripheral blood flow disorders? Right, it clots them all up, just like this, right? Has all those, it builds on your vessels, right? So we get numbness, coolness of extremities, intermittent claudication, possible leg ulcers that aren't healing. A lot of you have probably seen that in wound care. You've been there. Raynaud's disease, that's a cold exposure or emotional upset that triggers a vasospasm. So a couple different ways to treat these. For those that are being caused by your hyperlipidemics, your high lipid levels, you've got your statins. right? And that helps improve intermittent claudication, decreases your lipid levels, the win-win. Then you have your ACE inhibitors that improves hypertension and peripheral arterial disease symptoms. Alpha blockers, the prazosin, is a peripheral vasodilator, so that'll help, right? That'll help dilate and get the blood flow to your peripherals. We like those. Calcium channel blockers, your nifedipine, does the same thing. Antiplatelets, we're going to talk about those here. And then antiplatelet with ginkgo biloba. Anyone in here do ginkgo biloba? No? They're all online? Okay, that's fine. It improves intermittent claudication. So a lot of different ways to help do that. So let's see. Then we have your xylostazol. It's an antiplatelet, causes vasodilation, treats intermittent claudication, and then your pentoxifylline. This one, what it does is it reduces the blood viscosity. So when you say blood thinner, this is like a blood thinner. Okay. It also improves the flexibility of the erythrocytes, so it can get through those vasospasms and the constriction, the blockage from the lipids, right? The buildup, it can get through there a little faster and easier. Okay. That is it for that. Any questions? I know it's a lot, Amy. Absolutely. You can text me later. Okay. Now unit 11. This goes over chapter 13, chapter 34, just these pages in 34, and chapter 40. And I'm going to kind of go backwards. So we're going to start with chapter 40 first. And 40 is our anticoagulants. Okay, so pathophysiology of a thrombus formation, right? We've got two different kinds. We have an arterial block or we have a venous block, right? And a thrombus is a blood clot, right? So we've got our blood clot either in the arteries or in the venules. Is that right? Yeah. Okay. So 3 different ways it's caused. It can be caused by blood stasis. So it's just sitting there. What happens when you draw blood and it just sits in the tube? It coagulates, right? If it's doing that in a tube or in a syringe, it's doing that in your body too. So we don't want blood to be just sitting around in our body, which is why AFib is so dangerous, because it just sits in your atrium. Then you have your platelet aggregation, right? They're all clumping together in your vessels and causing this this thrombus. And then you have your blood coagulation. So your platelets and then your blood. I've got a couple little I think I want not that one, this one.
Can be extremely serious, causing complications such as stroke, pulmonary embolism, or heart attack. 2 different types of thrombi can form, arterial thrombi and venous thrombi. Here we will focus on arterial thrombosis. Arterial clots are usually triggered by the rupture of an atherosclerotic plaque in the artery wall, exposing the contents of the plaque and subendothelial fibers to the blood. In the fast-moving blood of the artery, platelets are rapidly recruited and activated at the site of plaque rupture, and the clot grows quickly, stabilized by fibrin generated through the coagulation cascade. If the clot partially or completely prevents blood flow to the heart, this can cause acute coronary syndrome, a a collection of conditions comprising unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. Because arterial clots are rich in platelets and stabilized by fibrin, the primary antithrombotic treatment in the acute phase is a combination of antiplatelet and anticoagulant therapy. Guidelines recommend continuing antiplatelet therapy indefinitely to help prevent secondary clots from forming.
Okay. So arterial thrombosis. Not good, right? That's where you get your heart attacks, stuff like that, right? Then you've got our venous. Hold on, let me see if it'll show the venous one. That's not yummy. Oh, here we go.
Pathological thrombi can be extremely serious, causing complications such as stroke, pulmonary embolism, or heart attack. Two different types of thrombi can form, arterial thrombi and venous thrombi. Here we will focus on venous thrombosis. In the slow-moving blood of the venous system, changes in blood composition, a reduction in blood flow, or changes to the vessel wall can result in the formation of fibrin-rich clots. These clots form through activation of the coagulation cascade, culminating in the factor Xa mediated generation of thrombin and the thrombin mediated cleavage of soluble fibrinogen to insoluble fibrin. Fibrin forms long strands which are cross-linked to form a mesh that traps passing red blood cells and platelets. Over time, these build up to form a clot. If this kind of clot forms in the large veins of the leg, it is termed deep vein thrombosis, or DVT. Alternatively, a part of the clot may break away and be carried in the bloodstream to the lung. If it blocks one of the arteries in the lung, this is termed a pulmonary embolism and can be fatal. In either case, clot resolution is vital because of the key role of the coagulation cascade in the formation of venous clots. Anticoagulants, which target specific proteins within the cascade, are currently the guideline-recommended treatment for acute DVT and pulmonary embolism in most patients.
Hey, that's fun. All right. So both types of those thrombosis can dislodge and become an embolus, which is the pulmonary embolism type stuff, right? Strokes, stuff like that. So we want to prevent that. We don't like those. We have medications for that. Okay, so we have a couple of different kinds. We have anticoagulants, which act primarily to prevent venous thrombosis. We have our antiplatelets to prevent platelet aggregation. Then we have our thrombolytics, which dissolve already formed blood clots. Okay. Okay, our anticoagulants, they're used to inhibit clot formation. That's where you get your warfarin, your heparin, your enoxaparin, or Lovenox. Those do not dissolve clots. If a clot is already there, it's not going to do anything with that clot. Okay. It's used in patients with venous and arterial disorders to put them at a high risk for clot formation. So I know there's a whole bunch on there, but we've got our DVTs, pulmonary embolisms, coronary thrombosis, MIs, artificial heart valves, and strokes.
Is that like
What?
Is that a wink wink?
Maybe. No. What puts them at high risk and that you'd use warfarin, heparin, or enoxaparin for these types of things? Okay, so heparin. Heparin is used for as a rapid anticoagulant. So somebody who is getting surgery and needs something quickly, right? This talks about open heart surgery to prevent blood from clotting. Okay. Anyone that develops DIC, heparin is used for that. The primary use for heparin is to prevent venous thrombosis, okay, because that can lead to a PE or a stroke. Who's given heparin in clinical? A couple of you guys. Okay, so heparin is only used in the hospital. You cannot get it through a prescription. This is the cascade of how it works. You guys can study that. Here's another one of those word things, if that helps you remember things about heparin. You can study that. Okay, so given sub-Q, for all those who haven't given heparin yet, given sub-Q for prophylaxis. It can be given IV. So you might see some continuous IV treatment in the hospital. It can't be given orally because it's destroyed by the GI. Okay, so it's just sub-Q or IV. It prolongs the clotting time. So we want to check our PTT levels. Okay, this heparin is used quite often, but you'll have a lot of blood tests with it too to make sure that they're within therapeutic ranges. Okay, it can decrease your platelet count, causing some thrombocytopenia, which is another reason why they check levels. And then what are signs of bleeding? One thing you want to watch for when giving any anticoagulant, what types of things?
Bruising, petechiae.
Bruising, petechiae.
Decreased blood pressure.
Pain, decreased blood pressure. What about stools?
Stools.
Or black tarry ones? Either one, depends on where they're bleeding from, right? So either one of those. Okay, but yay, if we overdose on heparin or if we're on heparin and there's signs of bleeding, it has an antidote. Protamine sulfate. Okay, so anyone that's on high doses of heparin, you'll want to definitely have that on hand, close by. Okay, protamine sulfate for any problems with the heparin. So here we go. Let's see, you can get aching, chills, injection site reactions. Obviously contraindicated if you have a bleeding problem already. Definitely be cautious in peptic ulcers, hepatic renal diseases, any head trauma. Why head trauma?
Because there could be bleeding.
Increased risk of bleeding, right? And if they have some kind of hemorrhage in their brain, you're just going to make it worse. No bueno. Okay. Increased effects with, what's ASA? Who remembers what ASA is? Aspirin. Okay, ASA is aspirin. So you're taking with aspirin, NSAIDs, thrombolytics, some antibiotics, SSRIs. Why aspirin and NSAIDs? Right. Because that's one of their side effects, right? It's increased risk of bleeding. So you put those two together, we're going to have problems. So remember to monitor your PTT with heparin. Okay, so now our low molecular weight heparins. So what they did is they looked at heparin and said, this is all great and good, but there's a lot of, like, it has to be used in the hospital. There's a lot of testing to do. Let's make this better. So they went molecularly, changed it a little bit. Now we have enoxaparin, which is Lovenox. Does pretty much the same thing, not as quick acting as heparin. So if you have somebody in surgery, you're not going to be reaching for the Lovenox. You'll still be wanting the heparin, but it has the same success as heparin, but it has a lower risk of bleeding. Okay, produces more stable responses, frequent lab monitoring is not required. Amy, wink, wink. Frequent monitoring with labs you don't have to do with Lovenox. It's fantastic. This stuff you can get at the pharmacy. You can administer it at home. It's given once or twice a day. Who's given Lovenox at clinical? A couple of you guys. Pretty easy. Okay.
It's like a surgical taper too, like warfarin you have to be off for 5 days, so then they'll break with Lovenox, switching to Lovenox for 3 days, and then DC, because it changes their PTT.
Yeah. So it's used as a bridge to get off the heparin. And if they do have to take it longer, like if they want them on something like heparin but have to take it longer, they can just discharge them on this Lovenox. So what type of things, if your patient's going on Lovenox, one really important thing is to educate the family members how to give it, right? Do we take the air bubble out of the syringe? There's an air bubble. If anyone's who's seen it, there's a little air bubble in there. Do we take the air bubble out of the syringe? No, we don't. We make sure it's at the top, right, of the plunger, so when you inject it, the air bubble just squirts everything out of the syringe, so you get everything out. Just a side note. Okay, so now the oral anticoagulants are famous Coumadin or warfarin. A lot of people call it rat poison, because that's kind of what it is. Rat poison is like a really high dose of this stuff. Yeah. A side note, did you know that mice can't fart?
That's interesting.
Like the mice, I know this has nothing to do with this, but talking about rats, that's mouse poison that they put around in the yards, like that are safe for kids and dogs and stuff. Because if they eat it, all it does is it like increases your GI air. And so us and dogs, like we can all fart, so that doesn't bother us. But mice, they cannot fart, and so that's how they die. Anyway, back to warfarin and bleeding out. Okay, so warfarin prolongs clotting time and is monitored by the PT. Heparin's PTT, warfarin is PT and INR. Okay, so people on warfarin, they are getting lots and lots of lab values until they get to a therapeutic range and it's pretty stable. I'm losing people. Do we need to stand up and do some jumping jacks? Stand up, do some jumping jacks. I know, I'm so sorry. I'm trying to hurry through this. We still have a few more things to go.
Yeah, it's just so much information.
It is. I absolutely agree with you.
We're talking about in the family meeting, to see if we can rearrange the units a little bit. It's not gonna affect you. I mean, unfortunately, it is, what it is, but for next semester, we may.
Stick with the groups of drugs and then just know what drugs are in what. Because on your syllabus, on the list of drugs to know, so know those drugs, but then know just like the groups. You know what I mean? Like beta blockers, calcium channel blockers. And if you just know the groups of drugs and then where each of those drugs lie, should be okay.
That's how I was studying, and I did really good on last time's test, but then today's test, it was like 30 questions for nitroglycerin, and I got hosed. Like,
Yeah, same.
from doing that. So it was like I created this study pattern that I wasn't studying good, it wasn't helping, but I found a good pattern. And then this test was totally different test. It was not laid out the same, and so that study method didn't work for me this
That's
time.
exactly what I forecasted this
We're having to
morning.
be too.
Like, that's just unfortunate. So I don't really know, like, do I keep studying like that because it worked for the test before that, or do I not?
Cause there are like,
I don't know.
what we had done, we went to breakfast one morning and we were talking about different like study ideas and kind of bouncing ideas, and we were talking about like, well, as long as you get like the type of the class that it's in, you're gonna be golden as long as you know like what drugs are in that class, you know, kind of. And then like this test, I think other tests you'd have like the class kind of given a lot of the times. And so okay, well we know that it's the anti-androgen, so boom, we know what's gonna happen with that. And so I think a lot of us had gotten used to that study method. And then today it was kind of like, oh shoot, and then it was like taking time, and then it's like.
I even, like, I knew that nitroglycerin was nitrate, like, I connected all this together, but it was the fact that I didn't study nitroglycerin as a singular thing that much. It was like I was studying different classes, and I felt like I'd studied calcium channel blockers and potassium blockers, and then all of a sudden, there was like 3 questions on those, and everything was nitroglycerin, and so it was just, that's what threw me off, is it wasn't as much about all the general classes.
As it was about one
It's all
specific
about,
drug.
like, mostly those.
Yeah.
Oh, yeah, Selena.
Okay.
I can't believe they can hear me. They can't hear anyone, but they can all hear me. I have like angry voice. I have a lot of that voice, and I have angry voice. What if I get those with both? Okay, so I still like.
Yeah, I did.
You're
the now, where I'm like,
Okay, I feel good now.
Okay, are we good? Okay.
well, it's like,
Okay. So this. So back to warfarin. We're gonna keep treading through this. So warfarin is a medication that people will take long term. It's in a pill form. They'll make sure that everything is at a therapeutic level. And so their blood levels will be tested frequently until they're at a therapeutic level, and then periodically after that to make sure they stay there. So INR, there's the normal INR is 1.3 to 2. Patients on anticoagulant therapy, they want obviously to have it be just a little bit higher than that because they're at higher risk for getting blood clots, right? Let's see. So warfarin has a really long half-life and duration. We do have an antidote for warfarin, which is good old vitamin K. Okay, but it does take a little bit of time to work. So you want to be careful there because it's not like it's not like an immediate acting, but part of it's because warfarin has such a long half-life. So vitamin K. So people on warfarin, what is something that maybe they want to avoid? What? Falling. Yes, that's a good one. So education for anticoagulants. So be careful, right? When they're at home, they want to be careful to, make sure their rugs and chairs and stuff like that. So they want to be careful with falling. What else? Skin tears.
caffeine.
Caffeine. Why caffeine?
In the blood.
Alcohol too.
Okay. Watch for bleeding, right? Make sure they go in and get tested whenever their blood tests are. Even if they're at therapeutic level, they still test them every couple of months, right? What else? What about this vitamin K?
Oh yeah, because it would increase the effectiveness of it.
Right. So what has vitamin K in it?
But
Kiwis.
What, Amy? Green leafy vegetables. So that's your lettuce, spinach, kale.
don't worry. Don't need that.
I'm sure there are other foods that have some vitamin K, but those have the most. So you want to be careful. Mampu said spinach. Good job. Yes. Okay, so be careful with the green leafy vegetables. They're high in vitamin K.
I will.
I'll take potassium.
Okay.
Wait, yeah.
Yeah, bananas are potassium.
Okay. Cake plus vitamin K does not help care.
Sorry, you're just saying be careful with the green leafy because vitamin K is an antidote to warfarin, so it's gonna make the warfarin less effective.
Right.
Okay.
Yes. Correct. Okay. So bleeding, obviously a major adverse effect of warfarin. Drugs that can displace warfarin from binding sites and cause more free circulating warfarin. What happens with that? You have more free drug Right. Okay. Perfect, Amy. Toxicity, higher chance of toxicity, right? So your aspirins, your NSAIDs, corticosteroids, phenytoin, any oral hypoglycemic drugs for diabetes. Tylenol should be used instead of aspirin, and then decrease your diet rich in vitamin K. So if you have a patient that's on warfarin and they're like, I have a headache, I'm going to take some aspirin.
And they're vegan.
And they're vegan. Right. Maybe a couple problems there. We should probably do a little bit of education. Okay, another picture with warfarin. You guys can study off of that. Here, okay, so here is a little trick to remember which test goes with which drug. Because we have our PTT and we have our PT. And these are good test questions to know which one belongs with which. So heparin plus PTT is 10 letters. Coumadin. Or,
I'm delirious.
What? Wait a minute.
What?
Okay, this 10. Dude, you picked me up.
No, I was saying, because if you try with the other one, then you're like, oh.
warfarin works with this too. So Coumadin and warfarin have the same letters. So it works with this too. And then PT equals 10 letters. So that's a good way to remember which test goes with which drug and which one you're looking at. Because a lot of times when they take your labs, they'll do a PT, PTT, and INR all in one. So then you got to know when you're looking up your labs, which one am I looking at? Heparin. Oh, I want the PTT. Coumadin. Oh, I'm looking at the PT and INR. Okay, so there you go. Let's see. Looks like we kind of went over all of them. Obviously, watch for bleeding. That's a big thing. Okay, antiplatelet drugs. This is your clopidogrel. Plavix. That's the other word. So these ones are suppressing your platelet aggregation. Okay. These ones are good to prevent MIs or strokes with family histories, prevention of repeat ones, prevention in TIAs, prevention in clotting following cardiac valve replacement. Wink, wink. Now, this drug you can take with aspirin. Okay, and you actually get a better result from it if it's taken concurrently with aspirin. So, anticoagulants, no aspirin. Antiplatelets, we're good with aspirin. Okay, did you have a question?
Yeah, sorry, what kind of, do we need to know like which clotting factors any of these are affecting? Like, is that gonna be on the test?
No.
Okay.
Don't give my tip stuff.
No.
But you know it's gonna be somewhere in the book, so I'm just asking if it becomes messy
Next
real
question.
quick.
Yeah. Yeah, don't worry about clotting factors. Just know what they do in general. Okay? Antiplatelets suppress the platelet aggregation, right? Anticoagulants suppress the clot formation. Okay. Long-term low-dose aspirin therapy, we talked about that, is also good for platelet aggregation if it's just kind of minor. So let's see. I don't know if there's really anything else we need to know about this. It's prophylactic. A lot of these anticoagulants, antiplatelets are prophylactic because they don't do anything for already having clots other than preventing ones. So last semester I had this, and this was like the day after like the big first riot like happened. So I was like, oh no, is that too quick? It's like a riot, right? So I was like, oh no, this happened yesterday. Anyway. So anyway, too soon, who knows? Okay, now our thrombolytics. These are our clot busters. This is our altipase or TPA. Sorry, it cut off. It's TPA. Right there. Who's heard of TPA? Yeah. Use it a lot in the ER, I'm sure, Debbie. A lot, right? So these help with thromboembolisms, which can result in ischemia and necrosis of the tissue. This is your arterial blocks, okay? But you can get in really anywhere, but mostly in your heart, in your head. Those are the two main ones. Lungs are bad too. Anyway, so it takes approximately 1 to 2 weeks for blood clot to disintegrate naturally. So we want to speed that up, because what happens if you don't have blood for 1 to 2 weeks? Right. Damage is done. Damage is done. So who knows about like the stroke protocols and stuff in the hospital? Besides Debbie, because she knows them like the back of her hand. Okay, so what did they say with strokes? Like just in general, you have stroke symptoms, how fast do you want to get to the hospital? Like you want to finish eating lunch and like go to the movie and then be like, oh yeah, maybe I should stop over at the hospital because I think I'm having a stroke. Like no, as soon as possible. And this is why. Because it has to be administered within 3 to 4 hours, or it's really not, it's a moot point. It's not going to work.
So is that like per hospital policy? Because some of them say 6 hours. Like up to 6 hours, you can still administer a CPA. So is that like
I would say it's hospital.
It's most recent evidence. So again, your book might be a little bit out of date, and you're not going to be tested on, your hours get it, but it's evidence. Evidence shows it's a 3 to 4 hour window after that clot has happened that you have to get it out. We used to get TPA all the time for MI. We don't. We fix them. That's the reason why it's 90 minutes from the time they hit the door to the time they're in the cath lab getting it fixed. And so it's just evidence. Evidence shows this makes it better. Does that make sense? Because TPA reverses your clots, reverses the clotting factor. And you bleed from anywhere. Like I have had people bleed from their tongue because the tongue was dry. I have them bleed from their IV site, from their lacrimal duct. I mean, anywhere they can bleed from. And God help them if they start bleeding in their GI tract. And once you push that, you're committed. It's done. So it doesn't come with that risk. But then the alternative is you don't have the left side of your body.
If they're paralyzed.
So yeah, evidence-based practice says that it shows that the fastest you can get this in, the better. I mean, it's kind of seems kind of like common sense too. The hospitals can probably say, depending on the hospital, I could say up to 6 hours is results better. 6 hours versus 4, or just as good. I don't know, but usually it's within. If it's been past about 4 hours, they're just going to say, well, damage is done, because we can reverse the clot, but the damage is still going to be done, because it really doesn't take long.
Risk versus benefit.
Yeah, it doesn't take long for your tissues to die. So what the takeaway is that alteplase or TPA is a clot buster. So you already have to have a clot for it to do anything. Obviously there's risks, and it has to be given quickly within a certain amount of hours within symptoms. Okay, so it just has to be given quickly as to when the symptoms started, not necessarily pushed quickly. Does that matter, Debbie, how fast it's pushed?
No, it's programmed in the pump.
Oh, okay. So it just has to be administered
It has to start
within hours of symptoms for it to have really good effects.
They should monitor it every.
Oh yeah, you're one.
Yeah.
You're one-on-one with that patient.
Yeah.
Then they go to ICU. They don't get out of bed for 2 days, and
Yeah. Also assess their neurological status, especially if you're doing this because of a stroke, right? You want to make sure that they're still maintaining or getting better, at least maintaining.
It's like resurrection. I mean, I've had people come in that literally had nothing, and within 30 minutes of administering this drug, they're normal. I mean, other than occasional bleeding, but they're back.
Yeah, if we can restore that blood flow. Okay. So obviously there's a lot of contraindications, a lot of drug interactions, and then they're like Debbie said, that you can be bleeding from anywhere. So you'll just want to monitor that bleeding. Okay. There's another one. Thrombolytics. Okay. Any questions on those? Fantastic. Let me tell you, if you guys, let me just throw this out there. If you guys message me, and I'm sure it goes for Debbie too, after like 4 o'clock in Canvas, and you want to question that or want a result that night, you might want to text us. Because I don't go home and check my Canvas. So if it's after like office hours and you're messaging me from Canvas, just expect, or if you're okay with an answer the next day, we're good. If you need something like that night, give me a text. Okay, so this is chapter 13. It goes over a lot of the vitamins and minerals. I'm just going to highlight a few of them here. So vitamins, organic substances, populations with need of increased vitamins, those with rapid body growth, which are babies and children, right? Pregnant women too, because they're facilitating a rapid body that's growing, a body that's rapidly growing. Inadequate diets, malabsorption problems, talk about pregnancy, breastfeeding, debilitating illnesses, restrictive diets, such as vegans, Atkins. I think those are like all meat diet. Anyway, those types of things. So fat solubles, ADEK, water solubles, B's and C's. I heard a thing that you think of a fat deck of cards. Right? You have your A fat deck, DEK. Those are your fat solubles. Right?
Those are important. Like I had a guy that died from vitamin A because it was like juicing craze. So he thought, well, if I juice carrots, it would be great. And so for a whole weekend, that's all he did was eat carrots that he had juiced, and his liver exploded, and he died orange, literally. Yeah, because it was too much.
Oh my gosh, was that like 10 years ago?
Yeah. It was a
Shut
fat
up,
soluble
because I totally saw him go down the hall on my clinical day.
Yeah.
He was orange.
Yeah,
I have
orange.
never seen an orange guy before.
The liver cannot handle that much. That's why there's limits on these fat soluble vitamins. Not on your test. Helpful to know. Important to know, but
That's good.
not on your test. Yeah.
We're going to have to talk about that because I specifically remember that guy. He was orange as a carrot. I'm not even kidding. Okay, anyway. So vitamin A. Essential for bone growth, maintenance of epithelial tissue, skin, eyes, ears, not ears, probably ears, but skin, eyes, and hair, especially, okay? You get them in your dark colored fruits and vegetables like carrots, cantaloupe, mangoes, spinach, pumpkins, sweet potatoes. I'm sure there's a whole bunch more. If you get a deficiency, you have the first sign is night blindness, and you can get skin lesions, dysfunction of the mucous membranes. What?
Is everybody not blind? Is that me?
Night blindness, skin lesions, dysfunction of mucous membranes. I'm going to repeat that for you. Okay, excess doses. If you have an excess dose, it's a teratogenic effect, so be careful not to be juicing a whole bunch of carrots every day when you're pregnant. Thrombocytopenia, hypervitaminosis A. You get your hair loss, peeling skin, GI upset, lethargy. Did I say it wrong?
No,
I wouldn't be surprised if I did. Okay, real quick. Vitamin C aids in absorption of iron. So if you're taking an iron supplement, what would be nice to take with it to help absorb that iron? Vitamin C, some orange juice. Maybe not Sunny D. I don't think that's real orange juice. But but you're close. Orange juice. Orange juice or anything with vitamin C will help iron absorption. Okay. Okay, you get that in your citrus fruits, cantaloupe again, tomatoes, leafy green vegetables, green peppers. There's a lot of vitamin C everywhere. Vitamin C is not made by your body. If you take excess, it will just excrete it out. but you can get too much. I think it takes a heck of a lot though to get excess doses of vitamin C. Vitamin B12. So here we have cyanocobalamin. That's how I say it. Cyanocobalamin. Okay, so our vitamin B12. Vitamin B12 is stored in our liver. It's good for DNA synthesis. It's not good, it's essential for DNA synthesis. Development of the red blood cells. Okay, maintain our nervous system integrity. We get it in liver, kidney, fish, milk, eggs, chicken, turkey. Our vegans and can have problems with this.
Nutritional yeast, yeah.
Doesn't it come from like soil? Like the reason why animals get it is because they don't like wash it and clean all their veggies and stuff.
I don't know.
I'm
That's
pretty sure it's not produced in
comes in this.
animals. Like animals don't.
That's probably true
I
that
think,
it comes
we,
from
over sanitize everything we eat, so that's like why we don't get it.
because we wash the soil off of our
Yeah.
foods. That's
Potato crush out of the ground. Eat some dirt,
So
yo.
if you're vegan,
just eat dirt, you'll get your vitamin B12. Okay, let's see. So let's see. Absorption through the intestinal wall depends. So when we absorb it, it depends on the intrinsic factor in our gastric parietal cells. Some people have intrinsic factor problems, and if we do, it's called.
Pernicious anemia.
Thank you. Pernicious anemia. So if you have somebody coming in with pernicious anemia, you know they have a problem with their intrinsic factor. They have problems absorbing their vitamin B12. Okay, deficiency can be seen with use of metformin and proton pump inhibitors. I think metformin was just recently taken off the market. I think.
It was just like
You're right.
They're thinking about it, or they did it.
wasn't taken off the market, but there was like a recall for metformin.
Okay, that's what I'm thinking. There's a recall for metformin. Anyway, so cyanocobalamin is a synthetic vitamin B12. It's given, obviously, to correct the vitamin B12 deficiency. Nobody wants to just eat soil, right? So let's give it to you in a shot. It can be given IM. A lot of elderly people, like with home health, they'll be giving vitamin B12 shots.
Don't they put this in like bags for like?
Banana bag.
Banana bags?
Yeah.
Yep. You'll see them in banana bags and multivitamins. And then can't be given IV because of hypersensitive reactions.
so
Just on a side note, you know how much a banana bag costs?
$375.
Close, it's over $400.
Oh, yeah.
Hey, Mark, that's pretty close. Over $400.
The fiber. Vitamin B12, intrinsic green from fiber.
Okay. Iron. We kind of already talked about iron. What helps absorb iron?
Vitamin C.
Vitamin C. And you find vitamin C in citrus fruits. Okay. Iron helps with hemoglobin regeneration. You get it in a whole bunch of foods.
You're losing control.
I know. I got to keep going because we're almost done and I have a few more to go. So, okay. So one causes of anemia is iron deficiency. Are you taking a picture of that? Okay, so iron is really important during pregnancy. Okay, because of the expansion of the maternal blood volume and the excessive production of red blood cells. So it's using a lot of iron. So you need extra iron to help with that. Okay, especially in pregnancy. And
Does folic acid change any? Because they always say like iron and folic acid for pregnancy. Does that change absorption or anything with iron?
no,
The folic acid is totally unrelated to B12.
Yeah, so the iron helps with the hemoglobin. The folic acid is going to help with the neurotubes. Yeah.
Okay.
They found
Yeah.
evidence that showed that a lack of folic acid increases spina bifida. Those are horrific things. So, and that usually is formed before the mom even knows.
Yeah. Two very important things. especially iron with pregnant women. Okay, so certain antibiotics and antacids can decrease iron absorption. Look, improves absorption, vitamin C, it's on there. And we've talked about it like 20 times. So if any of you guys get that question wrong, I'm going to haunt you in your dreams. Got it? Say it again. Are you kidding me? I don't know how much more
And I have given you.
obvious
so-
I can be.
I've given you so many hints today on what I covered that, like, I probably could be fired. Just telling you.
Onset of action is not immediate, so it takes a little bit. People with iron deficiency are going to be tired, lethargic, just like really low energy. So it'll take a couple of days for that to improve. Now, it's also toxic to children. Okay, keep your iron pills away from kids, please, please, for the love. Along with a lot of other things, iron pills away from children, it can kill them.
That's the reason why children's vitamins no longer have iron.
Oh, yeah,
That's
kind
what's
of
done
weird
is
though.
that I'm
Like,
ironing
when
it.
you're pregnant, someone's
Please,
phasing out,
like, gotta be a
don't let them have it? Like, at what age does that change, or does their body like metabolize it differently? Sorry, I'm sure it's
I would
not
say
about
young
the
children.
Yeah.
I think-
It has to go with the body surface kind of thing, and the fact that it's just too much concentration for their small bodies.
Then why not small?
It's already
Because
pretty
they don't,
small.
because they taste so good. I mean, it's like when I was a kid, I just would down, aspirin, like the little bear, because they tasted so good. They were like oranges. I was like, killing myself.
When a lot of iron pills are like little red pills, so they look like candy.
But the iron and the vitamins, they take, oh, this is a gummy. I love gummies. They think it's, candy, and it's way too much, way too much.
Okay, last section. Biologic response modifiers, colony stimulating factors. So this is going to be really quick and easy. I'll just tell you the takeaways, okay? Okay. Hematopoietic colony stimulating factors are proteins that stimulate or regulate the growth and maturation and differentiation of bone marrow stem cells. Okay? They don't kill tumors, but they are helpful in cancer treatment, and we'll talk about why. They promote growth of normal stem cells and blood cells that they produce. So what happens in cancer treatment?
everything.
They kill everything, right? Your white blood cells are depleted. Your bone marrow is attacked. It's having problems producing red blood cells, white blood cells, all sorts of stuff, okay? So what these guys do is they decrease the length of post-treatment neutropenia. Okay, they deliver higher doses, so they permit a delivery of higher doses of chemotherapy. They reduce bone marrow recovery time, so your bone marrow can make red and white blood cells faster. They enhance the macrophage and granulocyte destroying abilities, so your chance of getting sick decreases, right? And it prevents severe thrombocytopenia after chemotherapy. So what we're talking about here is erythropoietin. Who's heard of that? Erythropoietin. Okay. So what this does, it's a glycoprotein. It's produced by the kidneys that stimulate the red blood cell production in the bone marrow. So we make our own erythropoietin. But for those people that need a little help, of course, we have it synthesized too. So why not help them out, right? So we give them this erythropoietin, kind of puts the body into overdrive and says, oh my gosh, we need more. We need more red blood cells. Okay. So these are mostly used in exclamations when blood transfusions are not an option. Okay. Serious complications are very high. So if somebody needs red blood cells, if their hematocrit hemoglobin is low, what do we give them? Blood transfusions, right? We give them more blood. That's the easiest thing, still pretty invasive, but less complicated. It has less side effects, potentially. This has serious complications, can be high. But when would maybe a situation be when a blood transfusion is not an option? Religion.
Jehovah's Witnesses.
That's probably the biggest one.
Wow, that was quick.
Maybe some supply. Yeah, blood supply. Maybe, we have another, God forbid, massacre somewhere and we don't have any blood, right? Give them erythropoietin. Now, black box warnings. Patients with hypertension. Why is that a problem? You're giving them erythropoietin.
More
Increasing the
volume
volume
in
of
there.
blood.
Right, it's increasing the volume of blood. You're getting a lot more red blood cells out there, right? Okay. A hemoglobin concentration. Right, Braden? More volume, and we're already hypertensive, so that's a problem. Concentration greater than 11 grams per deciliter. Their hemoglobin's probably just fine. They don't need any more. Okay. If they've had an MI, a stroke, or tumor progression, that kind of goes somewhat with the hypertension, right? The MI stroke, you're increasing your red blood cells, which is increasing your risk for an MI or a stroke, another one, right? It's administered sub-Q or IV. So erythropoietin stimulates your red blood cells. Here we go. Let's see. You can pre-medicate with, what's APAP?
Oh, man.
Aspirin.
That's
No.
ASA.
It's acetaminophen.
Yes.
Poor.
APAP. APAP is acetaminophen. Okay. All right. You definitely want to assess their health history because if they have a history of MI or strokes or tumors or anything like that, right? Black box. We don't want to give that to them. Okay. A lot of side effects, stuff like that. Okay. Now we have our granulocytes, colony stimulating factor, our filgrastim. What does this one do? Activates what? Neutrophils, right? Neutrophils are
White blood cells.
white blood cells. Okay, so erythropoietin, first responders. Erythropoietin did the red blood cells. This filgrastim does the white blood cells. Okay, so it helps decrease chances of getting sick because it's boosting your white blood cells. So it's really good for people who are immunocompromised, chemotherapy type people. Yeah.
Is this like the same idea as doing like, not a vaccine, but like where you do an injection of like increased immunoglobulin?
Oh, like the IgG, IgM type
Like the
stuff.
same idea?
It's the same idea.
Yeah.
Like what Cal was talking
Yeah, it's
These
similar.
are normally used in chemo, okay, because the chemo wipes out red blood cells, white blood cells. So this is trying to help the body stimulate more coming from your own, rather than the problems you'll have from a transfusion. Does that make sense?
Okay, there's that good stuff right there. With this one, the filgrastim, there's really not any real drug interactions that have been found, which is good, I guess. Yeah, good stuff. You can still get reactions, chest pains, any ECG changes, fevers, chills, stuff like that. All the good stuff you want to watch for, right? And we're done. That's it.
Someone got a donut for me. I'm sorry, that's way more important.
Yeah, I know that was a whole lot of information. Please reach out if you have any questions.
We have an exam Monday for Chantel stuff. It's really hot.
Definitely read your
Yes.
books.
So I
Take
probably
notes.
will
Any
do-
questions from you guys online?
On Monday, there will be the test blueprint on Monday. We will have a review on Tuesday. So bring your questions. We'll go
Okay,
over
Olivia.
this, information better. If you have any questions during the week.
Please let me know if you guys have any questions. Any clarification, anything like that.
So just pull it slightly towards it and then click it.
I turned it up in We're done.
The door does not want you to have your donut.
Are you done?
Yeah. For all you guys online, your drug cards are due today.
Yeah.
Remember, drug cards due today.
They're changed.